Hello and welcome back to Advanced Human Gross Anatomy. Today we have a pretty extensive dissection. We will be looking at the posterior mediastinum, the superior mediastinum, and the anterior abdominal wall. In a previous dissection, we've already removed the heart, which is located in the middle mediastinum. Which you've removed. Today in the superior mediastinum, we're going to look at some structures. On this slide we can see already the thymus, this gland up on top of the heart here. We'll see some great vessels, some important nerves. And then in the posterior mediastinum, to get to that, we will have to remove a little bit more of this pericardial sac, which you've already taken the heart out and removed you've made some doors, some flaps that will go over, that have cut kind of through the midline of the pericardium, opening it up. Here you can see how the anterior portion of the pericardial sac has been removed. We're going to have to get behind this to get to the middle mediastinum. So with the heart removed, we're going to have to expose a little more and remove a little more of that pericardial sac. Now, I do want you to be careful to try to preserve, if we can, that phrenic nerve. Here you can see the phrenic nerve as it comes right in front of the anterior scalene muscle. It comes down and joins with coming from the neck and joining with the in the pericardium together with the pericardial-phrenic artery as it comes down, and it will continue its descent down until it comes to the diaphragm for innervation. So the phrenic nerve comes from C345 in the neck. Off of those nerve roots, comes over inside the neck and joins with the pericardial-phrenic artery within the lateral walls of the pericardium. And so what I'd like you to do is try to preserve that as much as you can. You can take a blunt probe and tease free these structures from the lateral wall of the pericardial sac. The phrenic nerve and the pericardial-phrenic artery will look kind of like one thing initially on each side here. So carefully separate those, and just, if you can, lay them, they'll just kind of lay in the thoracic cavity behind this, if we can preserve that. Just, again, as a good reminder of where it comes from, where it goes to, and what it went through on its journey down there. Once the back part of the pericardium is removed, you'll be able to see the posterior thoracic cavity here, this middle mediastinum. Here you see the esophagus. The trachea coming down here has been cut on the top, and then the bifurcation of the primary bronchi on the right and left have been cut off here. So you can see the esophagus coming down. You see the thoracic or the descending aorta coming down. Some important nerves that we'll take a look at here. The vagus nerve is a very important nerve that I'd like you to find in today's dissection as well. It comes across the arch of the aorta. Here you can see it coming down on the left side. So on the left, it's going to come down across the arch of the aorta within the superior mediastinum. Now, in a previous dissection, we cut across the manubrium, which sits roughly right about here, which cut across. The arch of the aorta, though, is behind the manubrium, so it's found behind this. So it's going to be a little tricky today from what you're looking at initially to try to find that. So we're going to want to remove today, or be able to kind of pull up some of the manubrium. To do this, let me see if I can find a different picture here. Let's go maybe back to this one. Here you can see the first rib as it comes down, and the clavicle will be just above this. You'll notice that the subclavian artery and vein are kind of between the first rib and the clavicle here. But to remove this, what we're going to do is remove part of the clavicle about halfway to the acromion. Now, I really want you to be careful as you do this, not to damage or cut the underlying tissues, or the subclavian artery or the subclavian veins here. Okay, so if you take a mini hacksaw and cut that clavicle on each side about halfway from the manubrium to the acromion process of the scapula, you'll be able to kind of pull up or kind of retract back the manubrium as it kind of pulls up. So you'll also need to get that free, though. You'll need to kind of cut that first rib. Now you'll notice that the first rib is very flat. It's very broad, very wide, wider than you might think, flatter than you might imagine here. It's underneath the clavicle. Again, the subclavian artery and vein are between the clavicle and the first rib. So you might need to take a nippers and cut that first rib kind of as far back as you can reach there. And the hacksaw cutting the clavicle here and here, and then you should be able to now kind of pull up on the manubrium, pulling it superiorly to expose the arch of the aorta. So as you come down back to, let's go to this one here. As you come down, this is fine. As that vagus nerve, now you'll be able to see that arch of the aorta as it comes down, as it comes into around the arch of the aorta. Now, what's different about the right and left sides of the arch of the aorta here, of the vagus nerve rather, that travels down between the the left subclavian artery and the left common carotid artery, which is a pretty thick strand, kind of coming right down here, that vagus nerve. And then it gives a branch that loops underneath the arch of the aorta and goes back up. It ascends then back up kind of on the sides of the esophagus here on the left side and becomes the recurrent laryngeal nerve. Now the recurrent laryngeal nerve, as it travels up kind of alongside that toward the trachea and the larynx, this is what gives most of your the major innervation to the muscles that for phonation around the larynx. It also continues to ascend further into the neck and becomes the inferior laryngeal nerve. Okay, now on the right side it's a little bit different. The right side does not have the arch of the aorta. So the vagus nerve, you can see it drops down down here between the subclavian and the common carotid, like I said, and loops around. On the right side, it's just going to come down and loop around the right subclavian artery as it loops back up and around. Here you can see the loop coming up towards that sides of the esophagus again. Just like on the left side will become the recurrent laryngeal, and then a little further up becomes the superior laryngeal nerve, again going towards the larynx, supplying most of the motor innervation for the muscles for phonation at the larynx. The recurrent laryngeal nerves, again, you can see on either side of the esophagus coming up toward the larynx. After it goes down on either side of the bronchi, the vagus nerve, you can see here, it kind of forms, and I'm going to go back to this slide here, a little more, this artist, Netter, drew it in this one a little more white than this slide here. It's more yellow, the nervous tissue. But if we look back at this one, after that vagus nerve comes down around that arch and it continues down, and joins with, in a previous dissection we looked at the sympathetic trunk. It will join with the gray rami of the sympathetic trunk and form the cardiac, the bronchial, and esophageal plexuses. Now this is both sympathetic and parasympathetic innervation together, and like we said before, we're not going to be able to identify what's what through those plexuses. It's parasympathetic from the vagus and sympathetic from the gray rami off the sympathetic trunk. But eventually down here, it does get its act back together, the vagus nerve does, and will form two branches. If I go back to this slide here, you can see it maybe a little bit easier, where it'll form on the anterior side, an anterior vagal trunk, and then this is on the side picture here, this is looking more toward the posterior esophagus here. You can see where it will form together on the back side to the posterior vagal trunk on either side of the esophagus. Okay, the vagus nerve. Now, as we look at circulation in the thoracic cavity, what's interesting about the circulation here, the venous return in particular, is different than the arterial supply. What's unique about this is the heart is in the way. So the venous return can't just go right. The vena cava is split here, where the heart would be. So the superior vena cava, remember, entering into the right atrium, and the inferior vena cava entering into the right atrium. the heart is here, so they can't drain those intercostal or those thoracic venous return can't just go right into the vena cava. It has to go into a different system, and that's called the azygous system. And so here on the right side, you can see what's called the azygous vein on the right side of the vertebrae here, right in the lateral vertebral wall on the right side. And the azygous vein drains these intercostal veins on the right side of the thorax, dumping them into the superior vena cava. Here you can see where it would come into the azygous vein and where it would go into the superior vena cava before it goes into the heart. Now on the left side, it's a little bit different here. On the left side, you can see there's what's called the hemiazygous vein. I'm sorry, the accessory. Let's see. Yes, the hemiazygous vein on the bottom here, coming this way, draining these intercostal veins on the left side at approximately the level of about T9 to about coming up. It goes behind the esophagus then. So maybe I'll show you a different picture here. Let's go to this one. Here you can see the azygous vein on the right. Here you can see the hemiazygous. So coming down to about from about T9, it comes across. Now you can see these branches coming over to the other side. What's really doing is it's coming over and joining with the azygous vein on the right side. Okay. Now a little bit above that, the accessory hemiazygous vein, draining roughly about the T4 to T8 or so, coming down through the mid-thoracic cavity here, draining those intercostal veins. And that again is going to also travel behind the esophagus and drain into the azygous vein on the right before it dumps back into the superior vena cava and into the right atrium. And then at the very top here, the very superior margin here, from the first through third intercostal spaces roughly, you've got another vein called the superior intercostal vein. Now this vein won't necessarily drain into the azygous because it's too high, but it's going to drain rather into the left brachiocephalic vein here, which you can see. So azygous on the right, draining the whole right side into the superior vena cava. The hemiazygous, T9 or so down on the left, draining into the azygous. T4 through 8 roughly on the left, draining into the accessory hemiazygous, going into the azygous, behind the esophagus again. And then the superior intercostal veins, draining the first three intercostal veins, dumping back into the left brachiocephalic vein before it will enter the superior vena cava and then again into the right atrium. Okay, so a little bit different on the venous drainage of the thoracic cavity. Now the aorta, as it travels down into the thoracic cavity, called the thoracic or the descending aorta, coming down here, also give branches off the back, and we've seen this already with the intercostal arteries going right into the costal groove on the left, crossing in front of the vertebrae. It's got to cross over the front of the vertebrae here to go into the costal groove on the right side. So immediately off of the thoracic aorta on the left into the costal groove, coming over the vertebrae behind the esophagus here. You can see kind of a branch of it here. Here's another one coming off towards the right side. And then you also have off of here some bronchial arteries. Now, we've talked about the pulmonary veins coming off of out of the pulmonary trunk, going to the lungs from the right ventricle as blood pumps out of the right ventricle. But those are mostly supplying alveoli, which is where the gas exchange is actually happening within the lungs. But the bronchial artery, these bronchial arteries come right off of the aorta, this thoracic aorta, and you can see here where they're innervating and giving nutrition and blood supply directly to the bronchi. You also have esophageal bronchi here coming off of the the thoracic or descending aorta, coming and innervating tissue off of the esophagus, coming down through there. And then showing just a little bit here, you've got some of that venous drainage of the bronchi too. You've got the right and left bronchial veins draining into the azygous system then. So they'll go into the azygous vein here, the bronchial veins. The left going into the accessory hemiazygous, which will eventually go into the azygous, and then the right bronchial veins just draining right into the azygous system. So that, I believe, well, let's keep going into the thoracic here. So also, let's change gears a little bit now and go talk about some lymphatic drainage. So also in the posterior mediastinum, you've got the lymphatic drainage system. You might remember learning this in your anatomy class with the lymphatic system. But these all head back. All of the lymphatics drain basically into two particular ducts. On the right side, I see the right lymphatic duct coming down and draining either into the right jugular here or the right subclavian veins. And this is going to drain lymphatics from the right upper extremity, from the chest, the thoracic cavity, and the head on the right side. So this is going to be mostly coming from the right side of those structures, draining into kind of the junction here where the right jugular and subclavian veins join. The other side, the other part here on the left, it's called the thoracic duct. Now the thoracic duct starts way down here at the cisterna chyli in the thoracic cavity, and it will either drain, like I said, it'll come up and drain either into that subclavian or the jugular on the left side before. But that's going to drain the rest of the body, the lymphatics from the rest of the body, from the entire, both lower extremities, from the abdomen, from the left side of the thorax, left upper extremity, left side of the head. It's all coming into that thoracic duct on the left side. Right is just draining the right side of the head, right upper extremity, right thoracic cavity. Left is going to be, the thoracic duct is going to be draining the rest of it. Okay, now if we show it kind of a lateral view here, it might be just a little bit different. You can see it's almost like they're looking at it from the side. So anterior on the left side of the slide, posterior on the right. Here you can see the vertebrae, the esophagus, the trachea, the great vessels. And here's what we were just looking at here, this thoracic duct draining in to the junction here of the left left subclavian and the left jugular right through here. But what's interesting about this is there's all these nodes in the thoracic cavity right here. And this is what makes it difficult. We've talked a little bit about breast cancer and how it can kind of transfer from side to side in a previous dissection. We talked about that. But here you can see these thoracic nodes. Within the cavity, lots of lymph nodes here. Makes it difficult to contain a cancer if it does metastasize in the thoracic lymphatic system. It can make it quite challenging to contain. Let's also look at the brachiocephalic veins. You'll be able to maintain, I think you should be able to see these quite clearly in today's dissection. Once you've lifted up that manubrium, as you cut that middle third of the clavicle and lift it up to see the arch of the aorta, you'll also be able to expose these brachiocephalic veins. The arch of the aorta isn't symmetric. But the venous return is. So the right here and the left brachiocephalic veins drain into the superior vena cava, which comes down into the right atrium. Here you can see a little bit again of the azygous vein as it comes kind of parallel to the esophagus on the right side of the thoracic wall, draining the intercostal veins you see here. Here you can see just as it enters in right there, you can see how it kind of comes up and enters into the superior vena cava before it would dump into the heart, into the right atrium. Let's see, what else do we have here? Here we can come back and see a little bit more of that thymus. You'll be able to see this today, but it might be tough to differentiate between the glandular tissue of the thymus and fat that just is going to surround the superior part of the mediastinum. So it overlies the superior aspect of the anterior portion of the heart. But with age, and it just, the thymus starts to deteriorate over time anyway, but the glandular tissue in the thymus, you'll maybe be able to see that it's a little more solid feeling than the fat or the adipose that's around it, that it's contained within. So it's maybe difficult to tell. A couple other areas in the body that we'll look at that we'll try to find the glands, but they'll be difficult to find. In the parotid gland, we'll look at that up in the face. Also down in the kidneys, the adrenal gland, we'll try to differentiate those tissues, the glandular tissue from adipose, but sometimes it can be tricky. Again, the best advice I can give you is that the glandular tissue is a little more firm, a little more solid in consistency than the adipose itself. So as you tease that away, you'll be able to kind of see that. As we look down a little bit further, let's come back to that arch of the aorta. I'll go to this picture. Well, here you can see the arch of the aorta. Here you can see the three vessels that come off of it. Let's look at this view here. This is a cadaveric dissection. You can see the heart here, this covered in that adipose tissue here. Here you can see the aorta coming up, the brachiocephalic. Here's the left brachiocephalic and the right brachiocephalic veins coming into the superior vena cava, into the right atrium of the heart. But if we look down kind of at a drawing here you can see the arch of the aorta a little bit better. Superior vena cava, again, coming in here. Here's the pulmonary trunk leaving. The left pulmonary artery and the right pulmonary artery coming behind the superior vena cava. But the brachiocephalic artery is the first artery to leave the arch of the aorta. This is not symmetric. Because the heart is slightly deviated to the left side of the sternum, underneath the sternum there, you're going to see that the brachiocephalic artery is about an inch or two long, where it comes back, and then it will split then into the right common carotid and the right subclavian. Here, probably a better shot here, you can see it, where it will kind of come off of the arch of the aorta, come across midline, where it will then bifurcate into the right common carotid and the right subclavian as it comes down. On the left side, though, the left common carotid just comes straight off of the aorta. The arch of the aorta goes right up, and the left common carotid and the left subclavian coming straight off of the arch of the aorta as well. Okay. Here again, we should be able to identify that phrenic nerve as it comes down in front of the anterior scalene muscle. Here you can see the phrenic nerve coming down, again joining with the pericardiochophrenic artery in the pericardial sac on the side of the pericardium. Travels down to innervate the diaphragm, which you can see kind of here as it comes down. Tough to, it's cut away. It's not the best shot of the phrenic artery, but you'll be able to see that. Here as well, you should be able to try to identify the ligamentum arteriosum. Now, there's a couple bypass systems in the fetal circulation. We talked about the foramen ovale within the heart, separating the right and the left atria, which becomes the fossa ovales. After birth, the foramen closes down. There's a membrane that will come and shut that down, so that the blood in the heart actually has to go from the right atrium to the right ventricle, and then leaving to go get oxygenated. Here's the pulmonary trunk as it leaves. But as some blood in the fetal circulation will come down and come into the left. Here, let's maybe show this shot here. Some blood will come down in from the right atrium, and instead of being shunted to the left atrium through that foramen ovale, what will happen, some of it will come down through that right atrioventricular valve into the right ventricle. And then when the right ventricle contracts to pump it out the pulmonary trunk to go to the lungs, there's another bypass system here where that blood can actually bypass the heart altogether and go right into the arterial supply, into the systemic circulation through the aorta. So this is a patent kind of opening of tube in the fetal circulation, because again, we don't need blood to go to the lungs for oxygenation in the fetal circulation. We can just bypass it and go right into the body. So in the adult after birth, this kind of closes down and becomes more of a ligament tissue, becomes more connective tissue. But again, it's that secondary shortcut of fetal blood supply that doesn't trying to bypass the lungs in that way. Coming back here, you can also see another term here is these tracheobronchial nodes. You can see them kind of around the trachea and the bronchi as they come down here. Now, this is lymphatic. These are in front of the bifurcation of the trachea, which is kind of behind the heart here. But these, if the person that we're working with today in dissection was a smoker, you can almost see them as black. They're very dark in their hue, so you might be able to take a look at that as well. As we come down now into the other part of the thoracic cavity, here's the trachea. Now, on the top portion here, you'll be able to see coming down from the larynx, you see the thyroid cartilage and the cricoid cartilage inferior to the larynx. Coming down now from that is the trachea. So these, you can see these rings here on the anterior portion of the trachea are rings made up of hyaline cartilage. You can see it kind of looks like a vacuum cleaner hose in consistency as it comes down. Because the airway needs to stay open all the time, these rings create kind of a rigid cartilage framework so that they can maintain their opening. So it's in front of the esophagus. Anterior, this shot here, you can kind of see the esophageal wall behind, but it's in front of the esophagus, and behind kind of the bifurcation here. Right here you can see where it would bifurcate into the right primary bronchi and the left primary bronchi. That bifurcation is kind of right behind the upper part of the heart, so it's behind the heart, in front of the esophagus, kind of sandwiched between those two structures. So the bifurcation of the trachea here, you don't need to dissect this, but if you were to kind of cut in through here, you can if you'd like. There's a little bit of a deflector. It's called the carina, which is a bit of a deflection to separate, so as material, which hopefully in this case, if it's in the trachea, hopefully it's just air, but it will kind of deflect air into either the right primary bronchus or the left primary bronchus. Now what's interesting is that the left primary bronchus, because the left lung, which we talked about earlier, is a little bit smaller than the right, and it's slightly deviated towards more that left side. It's got to go around the heart, so it's got two lobes that we talked about versus the three lobes of the right. Because it's slightly deviated over to this side and it is a little smaller, the left primary bronchi is both a little smaller in diameter, and it comes at a little steeper of an angle. It kind of makes a sharper turn to go over toward the left lung. It's a little longer, a little steeper angle, and a little smaller in diameter. Contrast that to the right primary bronchi, which is a little larger, and it's a shorter distance here. It just goes right to it just comes straight down. But it's a little bit thicker in diameter, and it's not as steep of an angle. So aspirated material, if you did get something in here besides air, sometimes you'll see x-rays sometimes of people that have inhaled. You're looking in the lung tissue, you'll see paper clips or fillings. Somebody, if you lose a filling and you swallow it and you inhale it, literally inhale it down the esophagus, down the trachea, not the esophagus, most of the time that carina will deflect it down into the right lung through the right primary bronchi. So that's what you can see there. So as we leave the thoracic cavity, let's now turn our attention to the abdominal cavity. In this dissection, we'll be dissecting the anterior abdominal wall. Now, you've already dissected the anterior thoracic wall, but we're going to continue that down into the abdominal wall. So what I'd like you to do is make an incision, kind of from where you stopped last time. You'll make an incision through the skin, down the midline of the abdomen, all the way down to the pubic bone. So you make a little loop around the umbilicus. As you cut down, you kind of cut around the umbilicus on either side. You don't want to cut through the umbilicus. We'll see in a little bit. There's some tough ligaments in that kind of anchor that structure from what it used to be from our fetal development. So we'll just kind of leave that alone. We'll cut around that, and then a loop around it, and then cut straight down to the pubic bone. And then from down here, you'll make lateral cuts down through the lower abdominal wall to the mid-axillary line on each side. And you've already done this superiorly. You've already cut here over superiorly. So now you kind of got just this abdominal wall. You can kind of flip this open like a door then as well. And here you can remove the skin, the subcutaneous tissue, and you'll be able to reveal some of this underlying musculature here. The first muscle that you'll see is the external oblique muscle. You'll see it on the right side of this picture here. So that'll be the first one you see as it comes down. But let's go a little bit deeper first here. I'm going to change this to this picture. Here you can see the external oblique has been cut away and exposing the internal oblique. But let's first look at the rectus abdominis. Rectus means straight. It's right at midline. There's one on the left side here. There's one on the right side here. The rectus abdominis comes straight up and down. And it's contained completely within what's called a rectus sheath, which is made up of the tendinous material from both the external oblique and the internal oblique, which we'll see in just a few slides here. But it's separated. What's unique about the rectus abdominis is it's got these separations, these tendinous material kind of compartments that it makes, these insertions that it makes coming down this way. This is what gives you the ability, when people talk about doing sit-ups and getting a 6-pack, here you can see 1, 2, 3, 4, maybe like an 8-pack or a 10-pack if you go real far down. You can kind of see some of these tendinous separations here of that rectus abdominis. But look at the fiber orientation. Whenever we're looking at musculature, always look at muscle fiber orientation. That'll give us a cue as to what its function is. But it attaches inferiorly down at the pubic bone and superiorly kind of at the margin of the ribs and the xiphoid process up on top. But again, the rectus sheath is formed by the internal and external obliques that come at angles to each other and completely surround the rectus abdominis musculature. So if we look back at the external oblique, let's go back to this slide here. You can see it runs laterally from superior to inferior. It runs from lateral to medial. It comes down and in at a side like this. It goes down just a little ways. It kind of stops here, and then it continues to form toward that midline. Imagine on each side. You can't see it on the left side here, but imagine on each side it continuing. But it forms into this broad, flat tendon. Now, the word we give for a broad, flat tendon in anatomy is aponeurosis. So that's what this is, this continuation of that external oblique toward the midline, way down to the pubic bone here, and the crest of the pubis, the pelvis here, forming over the top of the rectus abdominis. So it's kind of the superior or the superficial border of that rectus sheath. So what I'd like you to do in this dissection, if I go back to this, is make a small cut, a small window through the rectus abdominis. And you can do that kind of on either side here, but just maybe maybe right up through here. Make a small cut to be able to see, to expose some of the fibers of the rectus abdominis and see how they're going vertically up and down. What I'd like you to do then is kind of on the lateral abdominal wall, kind of underneath the margin of the rib, is make a 3-sided window, like a flap, maybe about 3 inches long, 3 inches here, maybe coming back to this way, from the lateral abdominal wall cut toward midline, and then down, and then back towards the lateral border, lateral axillary wall here, lateral abdominal wall there, creating kind of this flap that you can kind of pull laterally. But I just want you to expose, be careful not to cut too deeply here as you do this. I want to kind of make little windows here to kind of expose some of this musculature. Let's go back to this one here. The external, this is where I want you to do that, through the external obliques here, coming down, and then back, and then pulling this back. And you'll kind of see, so you can see the external oblique. Once you do that, you'll be able to expose these fibers of the internal obliques. Okay. Now from here, you can make a second flap just inside of that first window, cut another window coming down, down, and down, and then expose, and then kind of flip that back to expose the transversus abdominis. Here you can see the transversus abdominis coming more laterally. So internal obliques coming up and in, external obliques coming down and in, and transversus abdominis going straight back, coming around that way. So the fiber orientation, you'll see this a lot in anatomy, these 90-degree angles to each other. You'll notice the external obliques coming this way, internal obliques going this way, and then and then the transverse abdominis going this way. You'll see how they overlap each other. This just creates strength. This allows for strength. You'll see, like I said, you'll see this a lot within various parts of the anatomy. Another thing here just interesting to see is called the linea alba. Here you can see it fine, I guess. The linea alba, linea means line, alba means white, literally a white line connecting the epineuroses from the right side and the left side as it comes together, right at the midline of the body. Okay, let's continue down and explore some of the bones of the pelvis. I know we've seen, I don't know if we've done a lot of this yet, but let's just come down into the bones of the pelvis and see the pubic symphysis. Now, this just kind of gives us a good understanding of our abdominal attachments. So you can see the pubic symphysis here, where the two pubic bones come together. This is a fibrocartilage disc. A pad here that creates a bit of a cushioning between those two bones. It's an amphiarthritic joint. Amphiarthritic joints allow slight movement, so it does move a little bit, but it's just a slight amount. Connects those. If you continue to the left and right of this, just right off of that top superior portion of the pubic bone, you'll see the pubic crest right here on each side. This bony ridge on the superior portion. This is again that muscular attachment of the rectus abdominis. Comes down and attaches right to that pubic crest. On the lateral aspects of that, you'll see are the pubic tubercles. There are these two bumps on the sides here. Kind of bony prominences at the edge of the pubic crest. Those are landmarks that we'll be able to find as we come down and see the inguinal ligament. So the inguinal ligament comes down from the anterior superior iliac spine. If I show it here again, from the anterior superior iliac spine on each side of the ilium, the iliac bone here, the ilium, coming down. Going to the pubic tubercle, there's a ligament right through here that connects these two. Okay, the lower. This is also inguinal ligament is the lower edge. If I come back to here, it's the lower edge of the external oblique musculature, which you can see here. Okay. Try to find some good pictures here now of the inguinal ligament, or the inguinal canal rather. Both males and females have an inguinal canal right through here. It's more prominent in the males because in the male, which is shown in this picture, has a spermatic cord, which we'll see in future dissections as well. We'll do that extensively, I think, in the next dissection. We'll look at the spermatic cord, but it's more obvious in males. You can look for the the inguinal canal in the female as well. It's more of just theoretically, it's more of just a ligament, so it's a little harder to find in the female. But it should be there. If you wanted to look for that, that'd be fine. Here on this picture as well, you can see a couple different types of fascia. Here on the top portion, higher in the abdominal cavity, you'll see what's called the Camper's fascia, which is this fascia up here. It's a little more fatty in consistency. Down lower in the abdominal cavity, here you'll see is the Scarpa's fascia. Now, the Scarpa's fascia is continuous with the fascia of the around the thigh, which is called the fascia lata. So you can see a muscle on the side here, the tensor fascia lata. It's kind of underneath that fascia lata, that deep fascia of the thigh. But the Scarpa's fascia is kind of the lower abdominal fascia there. Sometimes, if you have a wound in the thigh, it can bleed up into kind of underneath that fascia lata. It will become consistent with or contiguous with that Scarpa's fascia. You can get bruising that ends up way up into your abdominal cavity. Which, if you've ever had a bruise, maybe up in your abdominal cavity, that kind of drains down, and you see a lot of bleeding or bruising up down into your thigh, or vice versa. Those are those fascia layers that are kind of containing that. Okay, let's see here. Down, I'm going to go back to this just as a review. You should, as you dissect down into this abdominal cavity, you'll be able to see some of these lateral and anterior cutaneous nerves. I know we talked about that way back when we started to look at the thoracic cavity, but even down into the abdominal cavity, you'll be able to see some of those branches of the lateral on the side, and then the anterior cutaneous nerves. As you remove the skin in the dissection, you'll be able to see that. You'll also be able to see some of those blood vessels in there as well, but it's a little bit difficult to differentiate that between the nerves. So that's where that's going to be. If we look here, a couple different terms to see. The inguinal ring here, the superficial inguinal ring. This is the exit of the spermatic cord in the male as it leaves to go to the scrotum. Maybe I'll show a different slide here. Here you can see that superficial inguinal ring right through here. This is where the cord, the spermatic cord descends down, actually from underneath the kidneys, way back here. In utero, it starts to, in the fetus, it starts to pull down as the developing fetus, the male fetus is developing. It starts to pull the testes down through that inguinal canal as they enter into the scrotum. But as it leaves here, that inguinal canal, the spermatic cord, that's the superficial inguinal ring. The deep inguinal ring is where the spermatic cord pierces through the transversalis fascia, which we'll see in a little bit. It's just the deep fascia deep to the transversus abdominis musculature. The canal that the spermatic cord goes through, the inguinal canal, is really only about 4 or 5, 6 centimeters long. It's not that long, so you'll be able to kind of identify that, especially in the male, when you can see the spermatic cord. You'll be able to kind of follow that up. In a physical, if a male patient is going for a physical, the physician will try to palpate up into that spermatic cord, trying to find, as it leaves that superficial inguinal ring, they'll try to palpate with fingers up into that space. The MD will ask the patient to cough to create some increased intra-abdominal pressure. And they're trying to palpate in case there's any presence of a hernia or any bowel or intestinal material or tissue that can kind of herniate through that superficial inguinal ring and come down into that spermatic cord area down here. So looking for an inguinal hernia coming down there. What else can we look at here? Internal obliques again. What's interesting about the internal oblique, I'll try to find a better shot of this. What's interesting about the internal oblique, and I'll show this in another slide in just a little bit as well, but the external oblique comes and forms that aponeurosis and goes in front of and kind of becomes the anterior portion of the rectus sheath. The internal oblique has its own aponeurosis, you can see here, coming in towards that rectus sheath as well. But this actually helps to surround that rectus abdominis musculature on both sides. So you can see it's going to come on the anterior side and on the posterior side of the rectus sheath, of the rectus abdominis musculature, containing the rectus abdominis musculature entirely. The external oblique covers just the front, while the internal aponeurosis, the aponeurosis of the internal oblique covers the rectus abdominis anteriorly and posteriorly, in front and behind. A couple more structures to see here on this slide. We'll just keep it on this slide. Yeah, we'll keep it there. This one shows the lacunar ligament. The lacunar ligament here you can see is on the back side of the superficial inguinal ring. It's on the kind of posterior to that. The spermatic cord goes over the top of the lacunar ligament. You might be able to notice that as it comes back. Joins the inguinal ligament with the inguinal ligament here to attach to the pubic tubercle. You can see there. So the lacunar ligament. Cremaster muscle. Cremaster muscle is kind of wraps the spermatic cord. Actually comes way up in through the spermatic cord, and it comes down and helps to elevate the testes to help regulate the temperature. The testes have a very particular temperature range that spermatogenesis happens in. It has to be roughly about 3 degrees Fahrenheit cooler than body temperature. And so the spermatic cord helps to elevate the testes in case the temperature is too cool, and it will bring the testes closer to the abdominal wall. If it's too warm, if the testes are warm, it will relax and help drop the testes down further from the abdominal wall. So again, just kind of creating, the scrotum needs to be outside of the body for that reason, because of spermatogenesis and the temperature requirement requirements of that need to be cooler than body temperature. So that's how that can happen. Cooler temperatures start to lift the testes up closer to the abdominal wall to maintain that temperature. Warmer temperatures will start to relax that muscle, dropping it down. Another muscle in there that kind of helps with this is, another muscle that kind of helps with this is the dartos muscle. The dartos muscle's within the scrotal wall itself, and this helps to help regulate that temperature of the testes and coordinate the efforts of the cremaster muscle as well. So the dartos muscle within the scrotum itself will contract, drawing up the testes and the contents of the scrotum closer to the abdominal wall. You'll also see here another tendon here called the conjoint tendon, conjoint or conjoined tendon, found on the medial side of the edge of the superficial inguinal ring, the medial side here. This is where the external and the internal obliques come together. So you can kind of see where that's joining here, this conjoint tendon. In front of the lacunar ligament. So remember, the lacunar is kind of on the posterior side. The conjoint tendon will be in front and kind of medial edge of that superficial inguinal ring as that spermatocord leaves the inguinal canal. Okay. Another picture here. This is just an interesting part of your anatomy with the vasculature. We've talked about the superior epigastric artery a little bit in the past. Remember the internal thoracic artery coming down from the so the anterior, kind of the inside edge of the thoracic cavity, thoracic or the mammary artery, we called it, coming down. That continues down through the diaphragm. It will continue down to become the superior epigastric artery. That will then branch off and supply the superior portions of the abdomen coming down here. But it's kind of on the inferior continuation of that internal thoracic artery. It goes right inside here. You can kind of see that rectus sheath. You can see it's opened up. The internal oblique aponeurosis has been opened here, so you can see the rectus abdominis held within it. Here you can see the posterior rectus sheath. Netter here has left us a couple of those chunks of rectus abdominis, so you can see that there. But the superior epigastric artery comes down inside of that rectus sheath. Now on the bottom side here is called the inferior epigastric artery, coming off of the external iliac artery, going down from the leg, coming up now in through the rectus sheath as well, and it will join with the superior epigastric artery inside of the rectus sheath. So really the inferior epigastric ascends into the rectus sheath, supplying the abdominal cavity. The superior descends into the rectus sheath, supplying some of the abdominal cavity. But they join up together. Now, what's interesting about this is people who have developed occlusions in the aorta over time have trouble getting nutrition down into the lower extremities. If that happens, you may find that these patients have a increased kind of like a bulge of these two arteries inside that thoracic or inside that rectus sheath there, as they kind of take up the slack of getting nutrition down into the lower extremities. So that's just kind of an alternate pathway for that. If we come back to this picture here, back to the thoracic cavity, you can see or the abdominal musculature here. This is kind of a cross section, so a transverse section cutting through. You can see how this is kind of, we'll call this above the belt line. Here is kind of below the belt line, so a little bit lower in the abdominal cavity. Here you can see the external oblique muscle coming over in front of the rectus abdominis, coming into that aponeurosis, comes in front. The internal oblique just below that. Here you can see splits. Again, above the belt line, you'll see it splits, and a portion of that will come in front of the rectus, and then a portion goes behind the rectus, but the rectus is completely contained within that sheath created by the aponeuroses of the oblique muscles. The transversus abdominis here you can see coming just behind that rectus sheath coming together. Now below the belt line, what you'll notice here is that all three of those tendon aponeuroses kind of come in front of the rectus sheath. So as the abdominal cavity gets lower, that musculature gets deeper. So you'll be able to see it's not quite as superficial. So all three of them come above that rectus. Now the transversalis fascia we mentioned before is kind of this line here, this gray line that separates beneath it. So it's kind of this fascia layer deep to the rectus sheath you see there. And then the peritoneum comes in and just wraps the entire abdominal cavity. So you can see the peritoneum here, kind of covering the rest of the abdominal cavity deep to the transversalis fascia. A couple more slides here. Just coming back to that inguinal hernia, that's probably a better shot of that. Here you can see pressure of the abdominal cavity pushes some intestinal material. You can see the intestines here. It pushes some of that intestinal material through the deep inguinal ring, against that deep inguinal ring. If it's bad enough, it will actually push through the inguinal canal and then become visible as it protrudes out of the superficial inguinal ring. So it comes through the deep inguinal ring here, through the inguinal canal, and then if it's bad enough, it'll actually push out the superficial inguinal ring. And then that'd be much more common in males than females because of the spermatic cord creating a little more of a space within that inguinal canal. But this can happen in females as well, just a little more common in males. The last slide that we'll talk about here, just a couple things to notice, is the falciform ligament. Now the falciform ligament is right up on top here. You can see it. This is where the only part of the mesentery that actually on the anterior abdominal wall will connect the liver to the anterior abdominal wall. You can see here the liver. So this picture is a little funny. You're looking at it from the inside, looking out toward the anterior of the abdomen. You're inside of the abdominal cavity looking out. So here you can see where the liver would be. This is actually part of the mesentery connecting the liver to the anterior portion of the abdominal wall. A ligamentum teres is kind of this at the lower free border of the falciform ligament. You can see as it comes down here and goes to the umbilicus right there. This is why we're not cutting through the umbilicus. It's just too tough. It's not. It's difficult to see. You'll see this this falciform ligament on either side of where you cut. As you flip that over, you'll kind of be able to see where that is, where that ligament is. But the ligamentum teres, another full name for that, ligamentum teres hepatis, on the lower free border of the falciform ligament. It's a kind of a rope-like. Teres means rope. You'll see that a lot in the naming of anatomical structures. So this is really a remnant of fetal circulation, this ligamentum teres. As the umbilical vein brings blood from the placenta to the fetus, that's what's happening through this, what then becomes the ligamentum teres. So the umbilical vein will become the ligamentum teres. At birth, this closes down and becomes ligamentum teres. It used to go through then, so the umbilical vein carrying oxygenated blood from the mother, from the placenta, going into the fetal liver as another means to help filter some of the blood from the mother's blood before it gets into the fetal circulation. So if a mother was smoking, or there was some drug use or things like this, it hopefully will go through the mother's liver before the blood goes into the fetal circulation. But if it doesn't, it'll go through that umbilical vein and then into the fetal liver first as another means of circulation as well. 3 more ligaments here that we'll see, and then we'll be done for the day. The median umbilical ligament, median, is right in the middle, right here. The median umbilical ligament, part of the developing bladder, which is kind of funny. It's from what's called the urachus, which is the part of the developing bladder. The bladder, as it's developed, it gets pulled down, pulled in, as the bladder develops through the wall, through what will become the umbilicus. So it kind of comes through that and continues down. You can see it continues with the bladder. It's a ligament as that got pulled in development. It's a remnant of that ligament it remains rather as a ligament as part of that bladder. You can see around the bladder here. Some people will have a patent urachus, which is just kind of this where urine can kind of back up partway into that what used to be a ligament, or what used to be that vessel now should be a ligament. But if it's still open, some urine can back up into that. On the sides of that here, you can see the medial ligaments. So median means midline, medial means next to midline, or near midline. These are remnants of the umbilical arteries now. So from off from the internal iliac arteries. The internal iliac artery also has branches called the superior vesical arteries, which supply part of the bladder. So you can see kind of they're coming off of that, going into the bladder here, superior vesical arteries. But then they continue as the umbilical artery, taking blood to the placenta from the fetus, again going out the umbilicus for oxygenation. So again, the fetal circulation, remnants of that fetal circulation. And then the last one here, the lateral umbilical ligaments on each side of this. You can see where the inferior epigastric arteries coming off of the inferior, the external iliac coming up, are going to join with the superior epigastric arteries in that rectus sheath again. So that's kind of, you can see those lateral umbilical arteries this way. Well, that's it. That took a bit, but I hope you learned something. I hope I did a good enough job explaining some of those structures that you'll be able to find today. And I will look forward to seeing you in lab. Thanks for your time.